everyone. I'm Monique Heusler. I am a registered nurse. I've been a nurse for about 5 years. I am in the graduate program here at Roberts. I'm getting my master's degree in education. So I am doing some teaching today, and we're going to be doing some oncology teaching and some end-of-life teaching as well. So we're going to start with oncology and go from there. Oncology nursing care, there is over 1 million new cases of cancer diagnosed in the U.S. in 2016. 591,699 deaths in 2016 from cancers. It is the second leading cause of death in the United States in 2016. Cancer mortality is higher among men than in women. It's highest among African American men and lowest among Asian Pacific Islander women. Not quite sure where those come in, but that's what the research has found. The national expenditure for cancer cure in the U.S. is $125 billion in 2010, and that's projected to be $165 billion by 2020. These estimated new cancer cases in 2012 is what I have found. As you can see, this is huge. Lung cancer is 224,000, breast cancer 230, almost 235,000 cases, prostate cancer 233,000 cases. The amount of new cases diagnosed each year of cancer is ridiculous. Does anyone know why these cases are being diagnosed each year? New cases of cancer being diagnosed each year? Screenings, very, very good. Because we have new technology, we can screen better for cancer. So more people are being diagnosed with cancer because of new screenings, because of our technology. So yes, more cases of cancer are being diagnosed. However, that also means that more cases are being diagnosed at a very low, what's the word I want to use? It's at a very low rate of where the cases are, so therefore it's a very high cure rate as well. So, the estimated new cases, as you can see in this one, prostate cancer in males is 180, breast cancer in females is 246,000. Estimated deaths. This is from 2016, so this is only a couple years ago. Lung cancers and bronchial cancers is 85,000 in males and 72,000 in females. The prostate cancer is 26,000 in males, which is only 8%, so that's actually pretty good. The prostate cancer actually has a really high cure rate if found pretty soon. Breast cancer is 40,000 in females. So this is actually pretty good, interesting information. Cancer is a disease process that begins when abnormal cells are transformed by genetic mutation of cellular DNA. Those cells are peripherally and can metastasize and destroy normal tissue. There are different kinds of cells. Benign tumor cells are slow growing, they're capsulated, they're non-invasive, they don't metastasize, and they're well diffused. Malignant cancer cells are fast growing, they demonstrate uncontrolled growth rate, they do not follow any physiological demand, they're invasive, and they infiltrate. Metastasis is an abnormal cells that have invasive characteristics, and they infiltrate other tissues. They have lymphatic spread and hematogenous. I can't talk today.
Just means that they spread in the blood.
Yeah, they spread throughout the blood. So the lymphatic spreads allow the transfer of tumor cells that can spread through nodes near primary sites. And then, so that goes through like the lymph system itself. And then so the other one, the hematogenous spread, it goes through the circulation, through your blood. And then the metastasis will follow a pattern of the venous spread. Let's see. So the different forms of cancer, you have carcinoma, the cancer that begins in the skin or in tissues that line or cover the internal organs. So you have adenocarcinoma, basal cell carcinoma, or transitional cell carcinoma. You have sarcoma, cancer cells that begin in the blood, cartilage, fat, muscle, blood vessels, or other connective or supportive tissue. You have leukemia, which cancers that start in the blood-forming tissue, such as bone marrow. You have lymphoma or myeloma, which is cancers that begin in the cells of the immune system. And you have central nervous system cancers, which cancers that begin in the tissue of the brain or the spinal cord. There are 4 stages of cancer. Stage 0 is carcinoma in the early situ, which is the early form. If that's caught early, usually it's a very high cure rate. And then it goes up, stage 1, stage 2, stage 3, and stage 4. Stage 4 is usually a metastasize. Stage 1 is usually localized. Stage 2 is early localized. It can be advanced stage 2. Stage 3 is late localized advanced, and like I said, stage 4 is usually metastasized. Invasive cancer, usually you'll hear a lot about that with breast cancer. It can metastasize everywhere. Prostate cancer, any kind of cancer can metastasize. And it depends on where the cancer starts to where it can metastasize. So it just depends. The risk factors for cancer are viruses, bacterial, HPV, EBV, and H. pylori. Physical factors, sunlight, radiation, chronic irritation. Chemical agents such as tobacco, radon, pesticides, dyes. Genetics, familiar factors, the BCRA genes, colorectal cancers. Diet, high-fat foods, ETOH, salt, cured, smoked meats, a lot of nitrates are in there, and hormones like estrogen. Levels of prevention, their primary prevention, reduction aimed at prevention and health promotion. We want to give our patient education. The clinical trials are aimed at prevention and risk reduction. Secondary prevention is what we usually use for those who are at higher risk, screenings and early exams. A lot of girls, we start getting our pap smears done, and those who have a history of breast cancer in their family, they do genetic testing. Tertiary prevention, the monitoring for and prevention of reoccurrence or secondary malignancies. The diagnostic process, this determines the presence or the extent of cancer, evaluates for metastasis, evaluate function and involved or uninvolved systems or the organ of the bodies. Oh my gosh, sorry. They evaluate function of involved or uninvolved systems and or body organs. So if they found, say, a lump in the neck, that can be part of the lymph system, but it depends on how far that has gone. I have a history of Hodgkin's lymphoma, which is a blood cancer. I had a lump in my neck, but I had to have a PET scan to see exactly how far that had gone. Luckily, mine was a stage 2A, so it didn't go anywhere lower than my diaphragm, so it stayed right here. I had a tumor in the middle of my chest, so I had to luckily I had, 8 rounds of chemo and 40 rounds of radiation to the tumor in my chest to get rid of it. So yeah, yay, almost 11 years cancer-free, yay, go me. So it just depends on where the cancer is and how they screen and all that kind of stuff. So you definitely want to get screened when they find something. They're going to obtain tissue and cells for analysts, staging and grading. I had a needle biopsy done for that tumor, and they were like, well, we're not quite sure. So they had to go in and actually take the lymph nodes out. So usually that's what they do. They just go in and take wherever it is, they take a biopsy out. Includes ROS, PE, imaging studies, laboratory tests, and pathology analysis. Once again, they do PET scans, CAT scans, a lot of lab tests, X-rays. What else can they do? Lots and lots of testing. The biopsy, incisionals, and needles. Like I said, that needle biopsy, that long needle, and I think it was like this long, coming at your neck is not pretty. Not pretty. It was like this long coming at you. Luckily, they, put lidocaine there, so you don't really feel much of anything. But so they do a lot of testing, and they to kind of figure out what's going on, in there. The tumor node metastasis classification. This is how they classify what stage the cancer is in. So they go by where the tumor is primary, what lymph nodes are around it that are involved, and if it's metastasized or not. I'm not going to go through all of this. You guys can read this. This is actually really important, and to know how you can stage that cancer. The cancer therapy goals, they have preventative and prophylactic. You have vaccines, genetic screening, and surgeries. The cure is, the goal is to eradicate the disease and return to as much of a baseline as possible. The control is, there's no cure, but condition can be minimized or controlled with therapies that may bring about periods of remission. And then you have palliation. They are provided to patients who have severe, debilitating, and life-ending disease. Its goal is to relieve symptoms such as pain and to make a patient comfortable with little or no attempt to cure, but to manage the disease or condition that causes the discomfort. Curative treatment may be attempted, but sometimes they fail. So once a cure is determined to be impossible, then patients must learn how to manage the problem that remains. So while there is a chance that, we want that cure, obviously that's all we're looking for is a cure for cancer, there's a chance that cancer may not be cured. So while we treat as much as possible for that cure, there's always that chance that it's not going to be cured. Medical management, we do surgery, diagnostic surgery, primary treatment, prophylactic surgery, palliative surgery, and reconstruction surgery. Diagnostic surgery obviously is for part of biopsy to make sure, we have to know that it is cancer or not. Primary treatment, sometimes they can just take that part of the tumor out and then it'll be gone. Prophylactic surgery, usually you'll hear a lot of this in sometimes women who have the BCR gene will get a double mastectomy because they can help prevent breast cancer in having that double mastectomy. The palliative surgery is sometimes it just helps relieve the pain if they have that surgery. And the reconstructive surgery is for women who have breast cancer. They'll take the double mastectomy, and sometimes that helps as well. Radiation therapy, chemotherapy, hematopoietic stem cell transplant, biogenic response modification or modifiers, gene therapy, complementary and alternative medicine, and targeted therapies are all part of medical management. Complications to cancer therapy, alopecia. Obviously, we all know that cancer treatment usually causes hair loss. I got very lucky in the fact that I am half Puerto Rican and I have a lot of hair. And every time I went in for my chemo treatment, my nurses go, "You still have a head full of hair." And I was like, "Yes, but you have no idea how much is coming out in the shower." I lost about half of my hair, but I still had a head full of hair. Got very lucky in that. You get stomatitis, which is oral inflammation and pain. It makes it very hard to eat, so therefore a lot of patients tend to lose a lot of weight with chemotherapy. Radiation-associated skin impairment. You have arrhythmia, peeling, ulcerations, and necrosis from the radiations when they're radiating to your sites. You have nutrition problems, anorexia, nausea and vomiting, malabsorption, fluid and electrolyte imbalances. You get a lot of pain, fatigue. There was a lot of fatigue going through chemo and radiation. I actually found the radiation was more tiring than the chemo because I was getting radiation every single day, 5 days a week, every day. It was more tiring than the chemo. Infection, that is huge because chemo does what to your body? I'm sorry?
Decrease your immune system.
It decreases your immune system, yes. So when we have patients who are going through chemo, we try to make sure that they stay away from people who are sick as much as possible, because your white cell count, we deplete your white cell count completely. It basically takes away your white cell count. Your ANC is less than 500. You know, you want to make sure that you're staying away from sick people because we don't want you to get sick as much as possible. You get thrombocytopenia, petechiae, ecchymosis, bleeding, and hemorrhage. It can cause that as well. You have body image disturbance and depression. Yes, absolutely. You go through a lot of depression when you go through chemo. It's a very, very hard thing. You need to have a lot of support, a lot of family members to support you. Friends, family are very important. I actually had my nurse practitioner, my doctor, my nurse practitioner would bring me dinner once a week. My family dinner once a week and just check up on me to see how I was doing. She wasn't my primary doctor because I was being taken care of by my oncologist, of course, but she was bringing me dinner once a week just to check up on me and see how I was doing while I was going through chemo. So the support is very huge. And obviously death can be an issue as well. Nursing diagnoses, because we are going to be nurses and this is huge for us. We have risk for infection is huge for cancer patients, risk for impaired skin integrity, impaired oral mucous membranes, ineffective coping is huge as well, impaired nutrition, less than body requirements, fatigue, activity imbalance, chronic pain, grieving and altered role functioning, disturbed body image. It's one of those things that you just want to make sure that your patients are being taken care of completely. If you ever go through or work on an oncology floor, the whole body needs to be taken care of. The whole patient needs to be taken care of, not just what you're treating. So you want to make sure that you're taking care of your whole patient. If they're sitting in there crying, go in there and comfort them as much as possible. Hold their hand if that's all they need. You don't have to talk to them, because most of the time they're just crying because they don't know what's going on, or they just need to get it out. And sometimes they just need somebody there with them to hold their hand. And that's all they want. So you need to make sure that you're being there for them as a whole person, not just for what you're treating. Nursing interventions, education. We need to make sure that we're always educating our patients. We're going to reduce risk reduction and prevention, treatment regimens, medication side effects. Medications side effects are huge when going through chemo. We talked about the side effects because nausea, vomiting is huge. They actually put me on steroids. So when I got my diagnosis, my original diagnosis, I was like, obviously I'm not the skinniest person in the world. I was like, okay, chemo, I'm gonna lose some weight. That was my positive thing for being diagnosed with cancer. My sister-in-law, who is now an NP, was a nurse at the time, and she went with me to my original appointment, and she goes, she's crying. This was my way of coping with it. I'm gonna lose some weight. She was bawling her eyes out. And I was like, it's okay. I'm gonna lose some weight. We'll be good. And she goes, mind you, I was 27. Okay, I had 2 young kids. My kids were 6 and 2 at the time. So I was scared. Absolutely, I was scared. But so I go, I'm gonna lose some weight, and she just starts laughing because she's overtired and I'm scared and start my chemo, and they put me on antibiotic or oral steroids, and I gain weight. And I'm like, What, are you kidding me? I gained 20 pounds going through chemo. I was like, come on, guys, really? I talked with my oncologist, and he's like, well, we didn't want you to have any nausea and vomiting. I was like, but you made me gain weight. So, but we need to talk to our patients about, and they never told me that I was going to be put on steroids. So that was one lack of education that they gave me. But we need to make sure that we're talking to our patients about education, about especially our medication side effects. Chemo is it's very hard to give our patients. We need to make sure that we're educating our patients about the side effects of chemo and what it can cause and what it does to our systems and all that kind of stuff. Obviously, they told me that I need to stay away from sick people as much as possible. Luckily, I was diagnosed in May, so I started my chemo in June. So during the summertime, it was easier enough to stay away from sick people. If you get diagnosed in the winter time, it's a little bit harder to stay away from sick people. Sometimes we do have to manage patients in the hospital with chemo and stuff if you're around sick people. But, we need to make sure that we're definitely educating our patients.
For the side effects thing, obviously the nausea and vomiting is the biggest one. Changing your appetite, because the nausea and vomiting can be very, very severe. My husband also went through chemotherapy, and the nausea got to the point where he really, I don't want to say he couldn't keep anything down, because he also gained weight during chemo, because the only things that he could eat were just like junk, like total junk, right? So it wasn't healthy food, but it's what he could keep down.
Right.
So like, it doesn't matter, just eat what you can keep down. But the nausea got to the point where it wasn't just when he'd have his round of chemo, and he'd be sick for a while after, but then when the next round was going to start, he'd start puking like days before the next round. And so, because it was like
anxiety.
It was the anxiety about like how bad it's going to be. So it's actually called anticipatory nausea. So they have medications that are like specific for that. And because he was having that so bad, he'd be throwing up for 3 days leading up to chemo. They gave him a medication for it. You get like your Zofran and your Reglan and all that kind of stuff like during chemo. And those are fine, whatever. But this one, it's meant for specifically anticipatory nausea. And so they put him on this one. It cost, as a copay to our insurance, not like just what it costs, like the copay per pill, $135 per pill.
Oh my gosh.
$135 per pill. And so he's like, it's not that bad. I can just throw up. But they wanted, because he was, your levels are low and electrolytes are off, so they want to control the nausea as much as they can, but it's chemo. There's sometimes just no way to do that. But those medications are really expensive.
Yes.
And Zofran is used all the time, and it's great, but at the time, this was a decade ago, Zofran, generic now, actually pretty dirt cheap.
Yeah.
But a decade ago, it was considered a tier 3 drug, because it wasn't generic yet. And so this was like 10, 12 years ago. That was like just to get a bottle of Zofran for each round. That was a $50 copay. So thinking about how our patients not only are dealing with the side effects, but we put them on medications to deal with the side effects. And we had a couple $100 each time just for the medications they had to take for it. So understanding how there's a lot of factors that are going to play into how they can manage what those side effects are.
Yeah, finances definitely go into it, so you need to make sure that they're understanding that too. My insurance was decent at the time, but I still had, I think I had a $60 copay whenever I got chemo, and then so I got chemo twice a month, and then every other time I went to go get my chemo, I had to see the doctor. So it was a $30 copay to see my doctor too. So every month I was paying, $60 one week and then $90 the next, just to get my chemo and radiation for 4 months. And then my radiation was $20 a day. A day. I got 40 rounds of radiation. 20 rounds of radiation. I was like, I can't afford this. I wasn't a nurse. I wasn't making nurse money. My husband was a mechanic. He wasn't making good money. I worked for ARC. I wasn't making any kind of money. We couldn't pay for that. Luckily, the cancer center that I went to had like and a lot of cancer centers do, they have like a donation program for people who survive cancer. They kind of donate money, and they have like a fund that you can apply for. And luckily my radiation was paid for through that, which was great because I couldn't afford the radiation, but I did end up paying for all my chemo and stuff like that. But yeah, so finances is huge. So you want to make sure that once, like I said, your whole patient is taken care of, and that your finances is huge to
And
take
these
care
are
of.
people
So
who are not working while they're going through treatment.
I couldn't work.
Even if you could, a
Yep.
lot of times your doctor will take you out. The infection risk is too great. And
Yes.
so my husband
Yep.
was a teacher at the time. They're not letting his
Oh, yeah, no.
immune system go to school.
Yep.
Like that's not going to work. So understanding these are people often who are not getting a regular paycheck. Even if they have disability insurance, it only pays you like 50 to 60% of your unless you have a really good policy. But usually.
Well, New York State disability is not good, so.
New York State disability, I think, is only 60% of your normal pay. So there's all these costs, there's all these side effects. The person's really sick, plus they're not getting their full income
Yep.
of what they might normally be getting. So there's a lot of things to think about in terms of how patients are going to juggle all that.
And back to medications, it changes your taste palette. So while you think, oh yeah, you can just eat, sometimes people don't have nausea and vomiting with chemo. It depends on the type of chemo that they're getting. It still changes your taste palette. So while I absolutely love pizza, could not eat pizza while I was going through chemo. Couldn't stand the taste of it. It changed my entire palate. I couldn't eat it. Couldn't eat tacos. I love Mexican food. Couldn't eat it. So it changes your entire taste palette too while you're going through this treatment, and it changes everything about you. It kind of sucks. So back to our nursing interventions. Sorry, screenings. We want to make sure our primary preventions are recommendations. So screenings for breast cancer, we do recommend that women over the age of 45 start getting mammograms. However, if you have a history of breast cancer in your family, I think they start recommending at the age of 40. Because of where they radiated to me in the middle of my chest, they did radiate some breast tissue. I actually started to go at 35. I'm not going to tell you how old I am, so we're not going to go there. But yes, I did have to start getting mammograms already. So it depends on what your history is in your family on when you're going to start getting all of these all these screenings. If you have a history of colorectal cancer in your family, you need to start getting screenings right away. If you have a history of prostate cancer in your family, you should start getting screened earlier than, I think 50 is the age of screening for prostate cancer.
Usually 50 is the age. They usually say if you have a first-degree relative that had that type of cancer, you subtract 10 years from when they were diagnosed, and that's the age at which you should start getting screened.
Yeah, so
if your mom had breast cancer when she was 38 and you're 28, that's when you should start mammograms. Or if grandpa, I don't think they count it. It's got to be first-degree relative.
yeah, I think
But if your dad had colon cancer when he was 45, you don't start colonoscopy when you're 50, you start when you're 35.
right.
It's usually subtract 10 years from whenever that first-degree relative had it.
So there's definitely screenings that we want to make sure our patients are well aware of for their children to start, especially in our elderly who we are most likely treating for cancer. We want to make sure their children are being screened as well. Genetic counseling, especially for our breast cancer patients, because the BCR is genetic as well, so we want to make sure their daughters are being checked for that. Home care, if patients are at home, we want to make sure that their home is well taken care of because we don't want any infections for our patients. Chemo is huge, like we've been talking about. It can cause toxicity, so we want to make sure that they're being checked on a regular basis, that we're not giving them too much chemo. It can cause some hypersensitivity. People have reactions to chemo all the time because it's not a drug that they get on a regular basis. So we as nurses are checking them constantly while they're getting their chemo. We want to make sure that they're not having any kind of hypersensitivity to the drugs that we are giving them. It can cause excavation to the sites that we're giving them. I got lucky and decided to get a Mediport put in because I knew the kind of medications that I was getting. I was going to have to sit for at least 4 hours each time I got my chemo, and I didn't have great veins at the time anyway, so I was like, the doctor's like, maybe you should get a port. I was like, yeah, that's probably a good idea. So I went and got a Mediport, so all you had to do was access it, and it was great because I didn't have to actually get poked multiple times for an IV. But chemo can cause excavation of the veins, so you want to make sure that you're checking that all the time. medication administration routes. So chemo can be administered multiple ways. It can be administered IV, it can be administered orally, it can be administered, some can be administered brachytherapy. So it can actually, prostate cancer is the most one that I know of. It can actually be administered through like these little capsules that actually go into the actual area and just sit in there. So it's kind of cool. And adjunct therapies. And we want to assess and minimize fatigue as much as possible. So we kind of tell them to do what you can and rest when you can. That's basically what we tell them. So basically do whatever you can, but we want to make sure that they're getting up and moving because we don't want them to develop, what? What's that?
Skin breakdown or blood clots.
Correct. Skin breakdown or blood clots. All right. So, other nursing interventions. Pain management is huge for our chemo patients. Cancer can be very, very painful, depending on where it is, what type of cancer it is. So we want to make sure that our patients are telling us when they're in pain. We want to make sure that we're treating their pain appropriately. We want to make sure that if they're being treated in the hospital that we're contacting the providers if the medications that we're giving them for pain are not helping their pain. We don't want to assume that what they're telling us for their pain is not the right number. Patients often tell us that our pain is a 10 out of 10 and we see them sitting on their phones and laughing and giggling. Cancer patients are not usually like that. Cancer patients, 10 out of 10 pain is a 10 out of 10 pain. So when we're giving them medications for pain and they're still saying their pain's a 10 out of 10, we need to make sure that they're calling the doctor and saying, hey, this medication's not working for our patient. Can we do something else? So we want to make sure that we're medicating for pain. I found that the chemo drugs that they were giving me caused major migraines. And so I talked to my oncologist, and he's like, well, what can I do for your migraine? And I was like, well, I don't know, but I can't do this. So I would get my chemo on Thursdays. I would feel good because of the steroids. So Thursdays I would feel good because I had my kids. I was a mom. I had to take care of my kids. So Thursday I would feel okay, Friday I would feel okay, Friday afternoon I would start to come down off of those steroids. And I planned my chemo on Thursdays for a reason. Fridays my now ex-husband would come home and he could take care of my kids. He didn't have to work the weekends. So I could rest on the weekends. And by Monday I would start to feel a little bit better. My oldest would be off to school and I could still take care of my 2-year-old. So I planned it that way for a reason. So but I would have migraines. Friday, Saturday, Sunday, Monday. I would have a 4-day migraine to where I could barely get out of bed on Saturday. It was that bad. And so I talked to my oncologist and he's like, well, what can I do for your migraines? I would end up I went on Percocet at the time. And I would have to take 2 Percocet about 3 times a day in order to help with my migraine. And it turns out it was from the anti-nausea medication they were giving me. And he's like, well, we can change that. I was like, we got 2 more rounds left. What's the point of changing it? Just give me the pain medication and I'll just deal with it, you know? So at that point it was just, so we want to make sure that we're taking care of our patient's pain as much as possible and as soon as possible. So always make sure that you're assessing your patient's pain. Psychosocial support is very, very big for our cancer patients. We want to make sure that they have support no matter what. Whether it's you, whether it's family, whether it's case management, whether it's friends, we want to make sure that there is support out there. Sometimes group therapy helps. Joining like an online support group, any kind of support that they can join is good for them because it helps with their mood. It helps with everything, and sometimes it helps with their outcome of the chemo and the cancer itself. Whether you think it doesn't, it does. So therapy, psychosocial support is huge. We're going to try to, as much as possible to promote adequate nutrition. We're gonna assess, guide, and manage their nausea and vomiting. So we're going to do what we can to give them whatever they can hold down. We're not gonna force them to eat or drink, but we're going to try to encourage as much as possible. Like I said, our taste palates change when you're going through chemo and radiation, so you wanna just encourage as much as possible them to eat or drink, because we want them to maintain their fluid and electrolyte balance. We want them to maintain their weight. Somebody who is already underweight and going through chemo and has nausea and vomiting and is losing weight is at serious risk for dying. So we don't want them to do that. Somebody who is even overweight and has nausea and vomiting is at serious risk for fluid and electrolyte imbalances and can be hospitalized. So we don't want that either. We want somebody to be able to stay home and be taken care of at home while they're going through chemo, because at home is the best way for them. Infection control practices, obviously, chemo lowers your infection rate, or lowers your white blood cells, and we don't want them to get an infection. Infection can cause them to be in the hospital. Being in the hospital can lead to more infections, so we want to make sure that they're being as safe as possible when they're going through chemo. Family and caregiver support, once again, that's huge. There are some patients that we have who don't have any family around to take care of them. So we want to make sure that there's somebody that we can help provide to take care of them as much as possible. And we're going to do as much as we can to modify to reduce the risk of complications. The safe administration of hazardous medications and therapies. You have to be certified in order to be a chemo nurse. There's a lot of certifications that you do in order to pass chemo meds. At Upstate, even though I am a travel nurse, I get floated to different units. I have gotten floated to the oncology floors before. I have taken care of cancer patients. I am not qualified to pass their chemo meds. So if they have a chemo med that needs to be passed, one of their floor nurses need to give them their meds. So you have to be certified in order to pass these meds. So you want to make sure that you're using a closed system transfer device. This prevents contaminants from getting into the medication, but it also prevents the drugs or vapors to escape the outside device. It minimizes exposure to you who are passing the meds. When I was going through my chemo, they would have when they were mixing all the drugs, because it was almost like it was an enclosed area, but you could kind of look into the area. It almost looked like a subway, to where, you know, they have, when you go in a subway, they have the glass there and everything gets closed down. So it had almost like a subway, and everything got closed down to where, and then when they were mixing it, it was all closed down, and they had areas where you can just stick your hands in, and they were just mixing medications. I would not want that, because I would be afraid that I would mix all the drugs wrong. But obviously, you get trained on all that stuff. You're going to use protective techniques when spiking and priming tubing. You're going to use chemotherapy tested personal protective equipment. They have special gloves that you're going to use, gowns, eye protection if needed, and respirator or mask if you're needing that as well. But definitely you're going to use the gloves and gowns for chemo, for passing or for hanging meds, or for passing any kind of chemo meds. And if you're doing radiation, you're going to use a dosage badge. So when we're giving radiation or doing radiation, they do, you want to have as less radiation as possible. My radiation was kind of interesting because they, when they start radiation, they kind of just mark on you where you're getting your radiation with X's, and you're not supposed to shower. And I'm like, well, I need to shower. And I'm like, well, don't wash that off. I'm getting it on my chest. How am I not supposed to wash off these X's? They end up tattooing you. And it's lovely. I have green dots on my chest. And it's kind of funny. You can't really see them unless you're up close. So I have, so they tattoo you where they line you up on this lovely, lovely machine. And it takes 5 minutes for me to get my radiation. So I was there for a total of 10 minutes every day to get radiation. 10 minutes. Took me 15 minutes to get to the radiation place. I was there for 10. But yeah, so they, but the people who were giving me my radiation, they wore all these dosage meters. They weren't in the rooms, but they were wearing these dosage meters to make sure they were not getting any kind of radiation too. It's kind of fun. It's very scary sometimes. You want, like I said, you want to make sure that your patients are being treated wholly, not just for the cancer that they're being treated for. Any questions? That's it for this one. Why don't you guys take a break?